Good afternoon, everyone. I think we've hit 12:30 Eastern, so we're going to go ahead and get started today. We have a lot to cover and a lot of interactivity, so we need to budget some time for that. My name is Scott Allen. I'm the CEO for the Family Medicine Education Consortium. And welcome to today's webinar, Too Many Pills, How to Choose the Right Oral Contraceptive. We're really excited to present this again. It was presented in September at our annual meeting in Arlington, Virginia, and was one of the highest rating, if not the highest rated sessions. So thank you, Dr. Kolpan, for coming back to help us present this to more people. Before we jump into the presentation, I want to just give a little bit of background about the FMEC in case any of you are not familiar with us. We serve 14 states in DC, so it's the northeast corner of the US. We are Ohio East and the Virginia's north. And we work with about, excuse me, if you could mute yourself if you're not on mute, that would be great. We serve about 60 medical school departments of family medicine and about 200 family medicine residency training programs. We do an annual meeting in the fall. If you haven't been, I hope you will come this October. It's October 13th through 15th in Providence, Rhode Island. And I want to do just a little plug for that meeting. If you want to submit a proposal, our call for presentations is now open. The deadline is February 13th. You can do a 1-hour session all the way down to a 5-minute session, lots of different formats, lots of different opportunities. And our meeting is a really great place for, especially for residents and medical students, to get some experience presenting. It's a really fun meeting over about 2 days over the weekend, Friday, Saturday, and Sunday. So with that, I am going to turn it over to Dr. Kolpan and our speakers today. But before that, just want to make sure you understand there are going to be some breakout rooms. When you are prompted, you'll see a little button come up saying join a breakout room. Please click join. The breakout rooms will be short, so you'll have about 2 minutes to discuss the cases we give you, and then you will see a timer and it'll count down. You'll come automatically back into the big group. So just want to make sure you know that. And also we did send out some handouts and we put links to the handouts in the chat. So if you didn't get them, you can click on those links in the chat. And with that, I am going to turn it over to Dr. Kolpan.
So this, sorry, the screen went wonky. Okay, hi, I'm Lori Turan-Kolpan. I am one of the core faculty physicians here at Hunterdon Medical Center's residency in Flemington, New Jersey. And with me, I have.
Hi, I'm Jessica Montez, a third-year resident here at Hunterdon. Pleasure to meet you all.
Okay, so a couple of things. I'm going to share my screen to do our presentation. Okay. All right. So we're going to go through our presentation today on how to choose the right pill. There are over 200 name brands of birth control pills out there. And I think what gets confusing is that there's not a right answer most of the time. Most of the time, there's several different choices for any particular situation. I know there's many choices, and everyone kind of has their favorites. Our goal today is to talk about what is in the birth control pill, right? So what are the components, the different hormones that are there, and specifically what are the side effects or positive effects of each of those things that's going to help you tailor the pill to your patient, particularly when you have someone coming saying, I'm complaining of breast tenderness, or I have irregular bleeding, or nausea or something. How do you change? What should you be changing? And if you think about knowing what's in the pill, it's going to be much easier to then pick something to change to. In your handouts, we gave you a list with just some definitions of what those different hormones are, what their side effects are. And then we also gave you a comparison of oral contraceptives, and the non-orals are also in there. I would say that this is from the prescriber's letter. It is a wonderful, wonderful, non-biased, educational tool they put out monthly. This is proprietary, so I would ask you not to share that. This is for educational purposes here, but I also want to give a shout out to the prescriber's letter as a really good evidence-based source of quick information. Okay, So we're going to start by talking about what's in the combined oral contraceptive. A combined means there's more than one thing. So that's going to be an estrogen and a progesterone. They do have some progesterone only pills, and we'll talk a little bit about them as well, but mostly we're looking at those combined oral contraceptives. We'll talk about the risks as well as the benefits, and then those side effects that are not dangerous, but they're annoying, and your patients will come complaining of them. And with that information, help us be able to choose the right pill. There are breakout rooms where we're going to do some, lots of cases. They are quick. I will admit, I've heard breakout room and said, no, thank you. These are going to be quick, easy, painless. There's not a lot that I think you'll enjoy it. So stick with us. Birth control pill a day keeps the minivan away. Always like something fun. Okay, so the estrogen. This is easy because for all intents and purposes, there's one. It is ethinyl estradiol, and the difference is all based on how much is in it. The dosing is 10 to 50 micrograms, but I will say that really, so there is a pill that has 10 micrograms, which is a very low dose. You're likely to get spotting with that, but if you're worried about estrogen, but still think it's okay, some people will use this. I don't think I've ever prescribed the one that only has 10 for the entire time. 35 micrograms is your upper limit of normal for contraception. It used to be 50, but we don't do that anymore. You don't need that high dose. That high dose is available mainly for treating uterine bleeding, okay? So really you're thinking between 20 and 35 as your dosing variant. There is one pill that has an estrogen called estradiol valerate. This is a prodrug that converts to estradiol. If you've ever done hormone replacement therapy, estradiol is sort of that bioidentical hormone or estrogen. There's no proof that it's any better tolerated than the ethinyl estradiol and is more expensive. The newest kid on the block is one pill that has esterol, which is a plant-derived estrogen, thought to be less selective at the breast tissue, but again, no proof that it's less harmful. So really, it's ethinyl estradiol and the dose. So one slide, we're done with estrogens. Now it gets more fun with the progestins. So there are 4 generations of progestins, and they all act a little differently. So the first group of progestins that were ever made bind estrogen, progestin, and androgen receptors, and they include norethindrone, norethindroacetate, and ethinyl diacetate. They don't bind the progesterone receptor strongly, so they do bind it. The issue is because they're not bound as strongly, you can get spotting, particularly if you're going to use a lower dose of one of those. So you would want to go higher or change to a different generation. So when would you use a first generation? Well, sometimes people are having progesterone side effects and you want that lower progesterone level. So then these first generation choices are nice choices of progestins to use. The second generation, the next kids that were made are testosterone derived products, and they include norgestrel and levonorgestrel. They bind the androgen receptor, and so they still have some residual androgenic activity. These are the most androgenic of all of the pills. So your androgenic side effects would be things like hair growth, acne, lower HDL, and they can alter glucose metabolism. They do have a much higher progestin activity though, so you'll get less breakthrough bleeding. So when would these be good? Sometimes maybe you want some of that androgenic effect. Like if someone's complaining of low libido, which is a side effect of the pill, maybe a second generation might be a really nice choice for them. But for my Apple configuration kind of folks, so more likely to have metabolic syndrome, they already have high triglycerides and low HDLs and maybe some acne or hirsutism. I avoid this for those folks. The next generation, third generation, these are still testosterone derivatives, but now they bind that androgen receptor weakly and they are still strongly progestogenic. So this is a great group. They include norgestimate and bezogestrel, great for people who have those androgen side effects. to move over to here. And then the fourth generation, these ones actually have an anti-androgen effect. So this is my group of choice. I want these kind of progesterones or progestins, and they're drospirenone or Dynogest. Drospirenone, so they, these are great for your PCOS patients or, again, those metabolic syndrome kind of folks. The drospirenone actually has anti-mineral corticoid effect, and it has the same potassium sparing effects as 25 milligrams of spironolactone. And most of the people you're prescribing this for, these are young, healthy women. I do not necessarily get baseline electrolytes, and I certainly am not checking them frequently. You do sometimes use these birth control pills on people with hypertension. We always are worried about ACE inhibitors in our reproductive age patients, but you may have a diabetic, you want that, and you're using birth control. If you're going to use one of these, now you're going to look at that potassium. Okay, so how do these work? Estrogen inhibits follicular stimulating hormone, so you don't get follicle formation. Okay, progesterone inhibits that LH surge. When you combine these together, you don't get ovulation. Progesterone's main mechanism of action, though, is thickening cervical mucus and thinning the endometrial lining. So in a progesterone-only pill, or if you were using a LARC with progesterone, you're not always inhibiting ovulation, but it's still very, very effective because that cervical mucus just becomes so thick that sperm don't penetrate, and then you've got that thin lining. Risks. So thrombosis is the one that we worry about the most, right? So, and this is any thrombotic issue, so cardiovascular disease, stroke, and venous thromboembolism. The risk here is really from the estrogen. So if someone has any history of a thrombotic event, they may not use estrogen. Okay, that's an absolute contraindication. Overall, this is a really low risk population for coronary disease and stroke. So you usually can feel pretty safe, even if they have other risk factors, control those risk factors, and you're usually fine. The greatest incidence for stroke is actually in patients who have migraine with aura. So again, migraine with aura is now going to be an absolute contraindication for using estrogen, okay? The risk of venous thromboembolism, so not stroke or coronary disease, but specifically venous thromboembolism, is higher in patients who are obese, mildly, okay? So you can absolutely still use estrogen, but you're just keeping that in mind. I always like to put things into perspective. So the risks of of a venous, a DVT rather, is in pregnancy is so much higher. They've got so much more estrogen. I'm more interested in them not becoming pregnant. I might talk about, make sure that I'm really talking about walking when they're on planes or long car drives or things like that. But obesity does not preclude your ability to use estrogen. And then very important to note, the risk for all thrombotic events is the highest in women who are greater than 35 and smoke. So in the United States, it's actually practicing outside of standard of care to give estrogen to women over 35 who smoke. The oral contraceptives, the combined oral contraceptives, specifically the estrogen, can raise blood pressure. This effect is more pronounced in some than others. I certainly want to get a baseline blood pressure before I prescribe the pill the first time. I think that's important. Once I have that, I do not need to repeat it. If it is a normal blood pressure, I don't bring them back for blood pressure monitoring. Both ACOG and the World Health Organization agree that combined oral contraceptives may be used in patients with well-controlled hypertension, but they are contraindicated if you have poor blood pressure control. If they are on antihypertensives, those are people that I will bring back to make sure that they didn't have a hyper response. In terms of lipids, estrogen increases triglycerides, but it also increases HDL and lowers your LDL. Progestins, particularly those androgenic, so your second generation progesterones, they lower HDL and increase LDL. So again, this is a reason why it's not my favorite choice for my metabolic syndrome kind of patients or ones who look like they might be heading in that direction. I certainly don't use lipids to dictate how I do the pill for the most part. Certainly, you know, by 21, we want to have a lipid panel. 18, you know, some would see even younger, just for good preventative health, but that rarely dictates what oral contraceptive you're using. The third and fourth generation progestins do increase HDL. Again, another reason why I like those for those metabolic people. In terms of cancer, there is a very slight increase in risk of breast cancer. What's important to note is that risk wanes with time off the OCP. So once you've hit 10 years off the OCP, the risk is the same as a non-user. So even in a patient with some significant family history, if they are young and this is the choice they want, it is fine to use. I might try to get them off estrogen if that risk is significant, you know, in their early 30s, so that they're back to a risk of non-users by the time they're early 40s. But again, this risk is very slight. In terms of cervical cancer, again, a slight increased risk. Hard to tell if that's truly from the pill or if it's co-founded by the presence of HPV. There is the possibility that the oral contraceptive allows the HPV to infect the cervix easier. And then hepatic risks. This is really kind of a non-issue for the oral contraceptive in terms of contraceptive use, because we really only see this in these pills containing 50 micrograms, but I put it in there because sometimes you'll see them on boards. So it can increase the risk of hepatic adenoma, not carcinoma, and then cholelithiasis and cholecystitis. And that kind of makes sense when you think about your risks for cholelithiasis are the female, fat, 40, fertile, right? So higher estrogen makes sense, you're more likely to develop gallstones. But again, at the low risk pills, which are your 20 to, or even 10 to 35 micrograms, we don't see this. Okay, I'm gonna turn it over to Dr. Montes.
So we just reviewed some of the risks associated with combined oral contraceptives. I'll be going over some of the drug interactions. So metabolism of the combined oral contraceptives, they're accelerated by drugs that increase liver microsomal enzyme activity. And these include phenobarbital, phenytoin, griseofulvin, and rifampin. The World Health Organization recommends not using combined oral contraceptives in patients on anticonvulsants or rifampin. Interestingly, griseofulvin seems to be okay. Though there are some anticonvulsants that do not reduce the effectiveness of combined oral contraceptives, there is some concern that it's the oral contraceptives that are reducing the effectiveness of the anticonvulsant. Also with the antibiotic rifampin is the only one proven to decrease effectiveness. There are anecdotal reports on tetracyclines, penicillin, and cephalosporins, but none proven. Also, St. John's wort, it may decrease the combined oral contraceptive's effectiveness. Studies show it increases metabolism of the contraceptive, and it leads to breakthrough bleeding, follicle growth, and ovulation. Some of the contraindications, we've gone over some of them, but some more are women, if they're greater than 35, who smoke. For the World Health Organization, they say for women, more than 15 cigarettes per day is a no, but less than 15 benefits may outweigh risks. But with ACOG, they're saying no for any smoker. So any woman greater than 35 who smokes, they don't recommend it. Also, migraine with aura, this increases the risk of stroke. Any history of thrombosis, like coronary artery disease, stroke, venous thromboembolism, any active hepatic disease, history of breast cancer or endometrial cancer, and any undiagnosed vaginal bleeding. So these are contraindicated if a woman has it. You would not give combined oral contraceptive. And some more are if a woman has significant hypertriglyceridemia, poorly controlled hypertension, they're postpartum in the first 6 weeks. We like to give no estrogen, so like a progesterone only pill would be best. Also breastfeeding, a progesterone only is preferred when they're breastfeeding, like I said. And also patients on anticonvulsants or rifampin, like we reviewed. There are some benefits as well to combined oral contraceptives. It significantly decreases the risk of ovarian cancer. There's a 50% reduction after taking it after 5 years. And the protective effects actually last for at least 30 years after stopping the combined oral contraceptive. There's a decreased risk of endometrial cancer, and those protective effects last for at least 15 years after stopping the OCP, and also a significant decreased risk of colon and rectal cancer. Other benefits are decreased anemia, dysmenorrhea, and menorrhagia. As we know, a lot of times we prescribe oral contraceptives not just for this birth control benefit, but also to help women who have these issues, and helps pain with pain and heavy bleeding. So for cycle control, also, we prescribe it for estrogen withdrawal migraines. They're improved with some regimens. Also for acne, hirsutism. There's a decrease. Another benefit is that it decreases pelvic inflammatory disease, reduction in cyclic mastalgia, and reduction in formation of ovarian cysts and pain from middle schmerz. Some of the side effects, the initial common ones that we hear a lot about are the bloating, the breast tenderness, nausea, and mood changes. When we hear these, we usually tell women to, keep on taking it. It's for at least 3 months. They usually resolve within 3 cycles. Another risk is breakthrough bleeding. This is the most common side effect. Also, amenorrhea. 5 to 10% of cycles are associated with amenorrhea. So we talked about the side effects, but this slide is nice because it tells you the side effects based on the hormone. So you can kind of tailor the birth control based on what side effect you want to reduce, and which hormone you want to kind of tweak. So the first one is estrogen. It's known to cause more of the hypertriglyceridemia, hypertension. It causes the breast tenderness, nausea, migraine, especially with withdrawal from it, headache, spotting with low dose, bloating, and some mood changes. The progestin, it also causes headache, but it also causes more of the mood changes, the spotting, and that's because of the thin endometrium, the breast tenderness, and low libido. And the androgens, they cause the hyperlipidemia, acne, hirsutism, and weight gain. And then I want to talk a little bit about breakthrough bleeding, because depending on when in the cycle a woman gets breakthrough bleeding, we can know what's the cause and how to adjust it. So if it's late cycle breakthrough bleeding, it's often caused by too little progestin. If it's early breakthrough bleeding, it's often caused by too little estrogen. And if it's mid-cycle, it's maybe a result of either hormone and it's being too low. It's hard to tell which one. And then this is a nice, funny comic. A man's driving. He's like, I can't remember if I took my malaria pill this morning. If I were a girl, I'd be pregnant a lot.
Okay. So we're going to go to some cases. I'm going to read the case and then we'll do our breakout rooms. You don't have the slides in front of you because I have the answer on the slide. And the biggest thing I want to say is there is not one answer for any one of these. I want you just to sort of think, are you looking for maybe a specific kind of progestin? I want a 4th generation or a 1st generation. Do I want, a specific amount of estrogen? If there is the name of the pill, like these are short cases, so you can jot down a note real quick, but I don't think there's two. If there's a name of a pill, you might want to write that down so you can look at it. And if you use this, the comparison of oral contraceptive chart, you'll see that Dr. Montez nicely put next to each progesterone, if it was a 1st, you'll see a 1, 2, 3, or 4. So you don't even have to remember the names. It will tell you if it's a 1st, 2nd, 3rd, or 4th generation progestin, and how much estrogen is it. And this is just a nice way to think about, well, what do I want in that pill? What generation do I want? How much estrogen do I want? Again, there's never one right answer, but just to sort of think about, okay? You're going to go put in breakout rooms, have 2 minutes to discuss it, and then come on back. So this is very different than the live, but we'll see how things go. Okay, are there any questions up to this point? Okay. And the cases are meant to also be teaching, so there might be some stuff in here we didn't go through in the lecture, but they're meant to really just sort of think about things. So our first case is a 20-year-old with no significant past medical history who wants to start on the oral contraceptive pill. Her periods are not heavy or painful. She has no contraindications. Her blood pressure is 120/80. Her BMI is 28. She smokes a half a pack of cigarettes per day. She's concerned about weight gain on the pill. So Denise, if you can, or Scott, whoever's putting people into rooms.
So I can say that in group. Go ahead.
So from group 2, we thought, to go with the type or first generation progestin, that those would probably have the least side effects as far as the androgens and the weight gain that she's concerned about.
Okay, all right. Did you have any particular estrogen dose?
We didn't discuss it. I know myself, I'd probably go with one of the relatively lower doses since, she doesn't have any real contraindications. I generally would probably go with anywhere from 25 to 35.
Yeah, fantastic, good. So the answer here is, oh, somehow I'm not on my slides. Oh, there we go. Anyone is fine. There is no contraindication for any particular pill. So she is concerned about that weight gain. So really, the first generation, they do bind androgen, but not nearly as much as your second generation. If I'm going low androgen, really your third and fourth generation and is going to be your best, with your fourth generation being actually anti-androgen. So the first generation they do bind, remember, bind the estrogen, progestin, and androgen receptor, all of them. So I would avoid second for her just because she's worried about that. The one thing I'll say is a lot of people say that they're worried about gaining weight. When you look at large cohort studies, the oral contraceptive pill, the combined, is weight neutral, okay? So now anyone who's prescribed pills long enough has had somebody who started on a pill and gained 4 to 8 pounds. If they gained 20 pounds, that wasn't the pill. But 4 to 8 pounds, I have absolutely seen come on when they start the pill and come off when they stop. We're all individual people, but just so that you know, in large cohort studies, these are weight neutral. That fourth generation does tout itself to be, because it's anti-androgenic, having the least weight gain, but I don't know that there's great proof for that. Okay, excellent. So hopefully the groups are going to work next time. Pick somebody in your group if you can, just so we can move it along, who's going to speak. And we'll go to the next case.
So for the second case, we have a 16-year-old female who got her period 2 years ago. She has regular periods that are very painful and that she feels are very heavy, no clots though. She has missed school 4 times now because of the pain. She does not smoke and has no other contraindications to an OCP. Her blood pressure today is 102/70 and her BMI is 23. So in your groups, I want you to all just think about, what kind of contraceptive you would prescribe her. Can anybody in group 1 give their thoughts or have any thoughts on this case?
Yeah, we were thinking a third or fourth generation progesterone with maybe like a medium to high dose of the estrogen.
Okay. And how come you were thinking that?
So she's having some painful and heavy bleeding. So maybe like the higher estrogen and then the progesterone for specifically the bleeding.
Okay, good. So for her, I don't know, this one. Click here. Perfect. So what it's saying is any contraceptive is the right answer. They will all significantly decrease her blood flow and her cramps. But like you were saying, Crystal, a high progestin activity and even an extended cycle would be great for her. So having more of that progestin activity than the estrogen would be really good for her. Okay, perfect. So we'll go to our next case.
And just to expand on that, a sconce. So absolutely love something with higher progestin activity that's going to thin the endometrium more, give her less bleeding, less shedding. And we know that that's what causes the heavy bleeding and the cramping. A third generation, also a very good choice. And I do like the higher estrogen. So again, you're just trying to minimize that bleeding as much as possible. Extended cycle, we didn't talk about that. So what exactly is that? Extended cycle is when you take the pill for a number of months. The traditional is 3, usually it's 84 active pills, and then you take the placebo pills. They come as extended cycle packs, or you can just give a regular pill and tell them to skip the placebos 2 out of the 3 months. Extended cycle is going to work best with a monophasic. The contraception will work if you use a triphasic or biphasic, meaning there's different doses of hormone during the month. It's supposed to help mimic your actual cycle a little bit. So like a trade name, like an orthotricycline or something like that, will have varying levels of hormone. If you skip the placebo pills and go right into the next pack, contraceptive wise, you're covered, but you will get spotting. So if you want to do extended cycle or continuous cycle, continuous means you don't ever stop. You just keep on going with active pills. You really need a monophasic, which has the same dose of estrogen and progesterone every day that you take that pill, okay? So when people are complaining of their periods a lot, having less of them is always an advantage. All right, case 3. You have a 15-year-old with acne. Her periods are regular, they're not bothersome. She notes that her acne gets much worse with her cycles. She has tried benzaclin, tretinoin, and she does not want to take an oral antibiotic. So take a moment and see what you think. Let's go with, are people getting put into different rooms, or are you all in the same room?
Different.
Different, okay. All right, so that's fine. I may call on people more than once, but it's, how about group 3? Anyone in group 3?
Our group said to stick with like a progesterone, specifically like a 4th gen, just anything with anti-androgen activity.
Perfect, perfect, absolutely. I love it. A 3rd or a 4th generation. Sorry, I was to click back in here to get that to come up. So a low androgen. So your 3rd or your 4th, and for her, I would like the 4th, is going to give, it'd be very helpful for acne. I would say actually any of them, once again, you can kind of use any because they will all decrease your sex hormone binding globulin and your overall circulating androgen level. So now there are a couple that are FDA approved for use for acne. That would be Yaz, orthotricycline, and estrostep. But really, any of the 3rd or 4th is a great option here. I would avoid the 2nd. That's the only one I would avoid. You can even go with the 1st if you want to. Just because something is FDA approved, that means that they paid the money to get that indication. It is fine to use specifically for acne. I'm hoping, you always hope that the 15-year-old wants to use it for that. Would be a good choice here. Are there questions?
Laurie, is there anything superior about a triphasic pill for acne?
So there are some people who like that concept, but there's no study to show that it's any better for acne than a monophasic, particularly one that uses the 4th generation. Yeah, some people think that there is, when you use the triphasic, you overall will have less amount of hormone, and that is why some people like the triphasic, but you can see 2 out of the 3 of these that are FDA approved were not necessarily triphasic. Estrostep, I think, is more the estrogen, not the progesterone. Other questions? Okay, moving on.
So for our next case, we have a 19-year-old female with migraine headaches. The headaches occur with the onset of menses. She has no aura with the headaches. And she has no other contraindications. Her blood pressure is 110/67, and her BMI is 25. So based on this, what contraceptive would you give her? All right, so I accidentally showed the answer. I apologize. So the answer for this is you would usually want, this is the headache is likely from an estrogen withdrawal because it's happening at the onset of menses. So what you would want is a pill that would help with the estrogen withdrawal. And what would be appropriate is using a multiphasic pill that has a low dose of estrogen in some or all of the week, and also the extended cycle. And with the extended cycle, they're similar to the continuous, except that instead of having the 7 days of placebo, you have that usually about every 3 months. So that'll prevent you having that withdrawal every month. Any questions about this one?
Yeah, on the handout, it also has headache as a side effect for the progestin. Is there a certain class of progestins or generations that has a lower lower side effect of headaches?
That would be more with the first generation because they have the lower dose of the estrogen and progesterone. So the first generations tend to cause less headaches.
Thank you.
You're welcome. All right, so move on to the next case.
Yeah, and the key with this particular case is that she's getting migraines, particularly with her period. So those are those estrogen withdrawal. If someone comes complaining of headaches that are not that, that's when I really want to look at that progesterone as a side effect. Even estrogen can do it. So I would look for first generation progestin that has like maybe 20 or 25 micrograms of estrogen. And I just want to point out that if you look at these, like if you go to page 1, 2, 3 of that chart on the biphasic pills, you can see you've got something here that has only 2 days of no estrogen. So if you go to the first set of biphasic, Mircet is a great, I used to love that one all the time for people with menstrual migraines, because in the placebo pills, there's still 10 micrograms of estrogen. So they only have 2 true pill-free days, and then the rest of them, they have just a little bit of estrogen, so you don't get that big withdrawal. So I just wanted to point out that there are some that where it's the placebo days aren't truly all placebo, and that's the reason why they do that. Okay, is there questions about that?
And Dr. Colban, there's a question in the chat. Could you give an example of which one of the multiphase you would consider low dose estrogen?
So if you look at that first set under the biphasic pills on page 3, so they're ethinyl estradiol of 20 micrograms. So a nice low dose of estrogen. You take that for 21 days. Then there's 2 days with no estrogen and 10 days, 5 days that have 10 micrograms of estrogen. So you're low dose the whole time, and that's desogestrel. So it is a 3rd generation progestin. It does have good progestin activity, but again, this is a menstrual migraine person where I'm not worried about. I don't think it's the progestin that's causing it. I think it's the withdrawal that's causing it, the withdrawal from estrogen. So some trade names, like I said, Mircet, Similia, Valora. Okay, any other questions? And thank you for telling me the chats. It's too much for me. Okay, let's move on to our next one. So this case is a 23-year-old who's on Janelle 120. And I will tell you that Janelle 120 has 20 micrograms of ethinyl estradiol, and it has norethindrone acetate, which is a 1st generation progestin. She is having spotting in the 2nd week of her cycle. What should we do for her? There's lots to talk about.
There's about a minute left for these breakout rooms. They're going in the breakout rooms. They're talking. I can see their little microphones moving. I don't know why they can't turn on their videos. I've tried to change that setting, but I think they're having discussions, I can see. So hopefully it's
Good.
working.
Good. It'll be interesting to hear what the feedback is
Yeah.
when it's all said and done. At least somebody's chiming in for an answer, and there's a couple questions, which is good. In the
Yeah,
live one, it was very lively.
Yeah, I'm sure. I don't this even if this was perfect, I'm sure it's never the same, but
Yeah.
but I can see multiple people talking in each room, so that's a good thing.
That is a very good thing. Sometimes too, it just takes a bit to get the shakes out.
Yeah,
They feel
about 10 seconds and they'll start popping back in.
closed.
One idea was that like changing from a first generation to second generation might lead to less breakthrough spotting in terms of the progesterone element or
Yes,
progestin
perfect.
element. Mhm.
Perfect. Great. You're noticing that she's on a first generation, which has your least progestogenic activity. She's having, I made this one tricky a little bit on purpose. She's having mid-cycle spotting, right? So can anyone, early cycle spotting, what's that usually the problem?
Estrogen.
Estrogen, good. And is she on a high estrogen?
No.
No, she's not. She's low. So this is a really interesting one because so the early cycle spotting is estrogen, thus the late cycle spotting, if it was a third week of her pill, you'd think, well, it's the progesterone, but she's got it in the second. So it could be either one. So I agree with the progestin. I also would increase the estrogen. I forgot to put the progestin in here when I did these answers. But I would actually choose any other generation, a second, third, or fourth. And I would also probably bump her up to 35. I mean, there's no reason she can't have a better dose of progesterone. And rather than kind of guess, do I just want to go to 25 or so? I would just go to 35 micrograms of estrogen, get her on some other generation of progestin, and then follow her up in 3 months. Whenever you make a change, just as Dr. Montez mentioned, you want to give them 3 months because those nuisance side effects and you can get spotting that's going to go away. So always try to get them to hang out for the 3 months. Okay.
Next case is a 30-year-old female with cyclic mastalgia on Levora, which is has the ethinylestradiol 30 micrograms and levonorgestrel 0.15 milligrams. She's a non-smoker. She has no contraindications. She drinks 3 large Wawa coffees daily, and her blood pressure is 133/75, and her BMI is 30. So based on this, what contraceptive would you give her? Anybody from any group? Any thoughts?
Group 3 felt we should lower the estrogen.
Okay, good. I agree. Cyclic mastalgia, it could be, we were just discussing, it could be from estrogen or progesterone. So I agree, going to a first generation would be a good move and lowering the progesterone. So what you can do is you can first lower caffeine intake and change to a pill with lower progesterone, a first generation. And in addition, you can also lower the estrogen. Okay, so the mastalgia comes mostly from the progesterone, but it can be also attributed to estrogen. So a safe thing would be to go down on both doses of both hormones, okay? All right, we're gonna go to the next case.
And we're getting towards the end, so we're just gonna breeze through these. We won't go to breakout rooms. I always like to bring up the caffeine thing when it comes to cyclic mastalgia because 3 cups of Wawa coffee, that's a lot of caffeine, and that could be your issue right there. Okay, so in this next case, you have a 35-year-old who wants to resume contraception after her last child. She was on the pill in her 20s without any issue. She had severe preeclampsia with her last pregnancy. She is a non-smoker. Her BMI is 33 and her current blood pressure is 155/89. Anyone give a thought?
No estrogen.
Fabulous. Absolutely. Progesterone only pill if she doesn't want another option like a LARC. She's 35. She had severe preeclampsia. If is done childbearing, you know, we know that the biggest risk factor for preeclampsia is having had it before. So, you know, not to dictate her reproductive history at all, but if she really doesn't want another one, going with something with a very reliable source of contraception like a LARC, and not that the pill isn't, but you know, I'm happy with that. But again, no estrogen, good. A 33-year-old with heavy periods who wants to start the pill. She's a non-smoker, no contraindications, blood pressure's 130/80. She has a BMI of 42. Any thoughts there? Okay, because we're just about done. I'm sure people are getting off. You can still use any oral contraceptive. The things I like to bring out is that obesity does decrease the effectiveness just slightly from 2 pregnancies per 100 to 3 pregnancies per 100 if the BMI is over 35, and actually using extended cycle improves that efficacy. And we talked before about slight increase in risk of thrombosis for obese patients. You may encounter some OB/GYNs that will refuse to give estrogen in women over 35 if they're obese. That doesn't have to be the case, but I probably would do a 20 microgram pill for this person. And then our last one is a 21-year-old going on vacation and wants to avoid menses. She's already on an oral contraceptive and just wants to skip the pill-free days. Is this okay? We kind of already said absolutely, and that you can do this for any pill, but if she was on a triphasic, let's say, she might spot during that time. Doesn't mean she can't do it though. And then how long is it safe to go without getting a period? And the answer is forever. You absolutely can do continuous contraception. And if you look on page 2, you'll see a couple of choices. So of it's the 1, 2, 3rd bracket down, has 20 micrograms of ethinyl estradiol and levonorgestrel. And it is the same dose for 28 days, and you just keep refilling that pack. So that would be continuous contraception. So that is our presentation. Does anyone have any last questions before we go? I want to thank you so much for joining us. I hope that you enjoyed the presentation and learned something practical. You can always email Scott if you have any questions, and he can put you in touch with Dr. Montes.